Welcome to everybody who is filing in for today's webinar. We'll be getting started in just over a minute at the top of the hour. Okay, welcome everyone to our webinar. We've got a few folks who are just shuffling, so we'll give it another, 15 seconds or so to get everyone settled in and logged into the audio, and then we'll go ahead and get started. Okay, so I'm going to go ahead and get us started here. So welcome everyone to the first webinar of our Solving for Sleep webinar series. The series is made possible by the SAMHSA Center of Excellence for Integrated Health Solutions. So today we're going to be really getting foundational about sleep. We're going to talk about why we need it. We're going to talk about what happens when we don't get enough quality sleep, who tends to be most impacted, and we'll also go over some essential steps for really improving sleep quality. And as we get into it, you've got a little chat box there at the bottom or to the right of your screen. Let us know who you are, but also how are you doing? There's a lot going on in the world right now, and there has been, and we'd love to just hear how you're making out. So next slide, please. And if this is your first time with us here, my name is Andrew Phillip. I'm a clinical health psychologist and the Senior Director for Clinical and Population Health here at the Primary Care Development Corporation. Next slide, please. Again, if you're new to us, Primary Care Development Corporation, we're a national nonprofit founded over 20 years ago, really to build equity in underserved and frankly, disinvested communities. And since the 90s, we've done this through capital investment to the tune of over $1 billion to enhance healthcare infrastructure around the country. We provide advocacy to really build policies that actually support enhanced and sustainable primary care services, really where they're needed most. And of course, training and technical assistance like today's webinar, as well as consultation on everything from health homes to behavioral health integration, HIV integration, prevention, reproductive health, and more. Just a quick disclaimer here, as you can see on your screen, the views that we're going to be discussing today and throughout this series are those of our presenters and do not necessarily reflect those of SAMHSA, Health and Human Services, or really any other federal entity. Next slide. So let's get to it. At this point, it is, it's clearer than ever before that integrated team-based care that really places the patient in the driver's seat of their care is really key to quality healthcare delivery. Our sleep series this year will really focus on screening, on intervention, and team perspectives that can really help us address sleep needs. And many of you actually attended our sort of pre-kickoff to the series where we hosted a town hall for health centers. And in that town hall, folks shared with us a number of frustrations in trying to address sleep for our patients, but also for ourselves. And so hopefully some of that is reflected in today's sessions, but also some of our upcoming sessions throughout the series. And actually, Jaime, you can go over to the next slide. So in the upcoming year, starting today, we're going to be focusing on kind of the core topics in addressing sleep health from an integrated primary and behavioral healthcare perspective. And that includes looking at, of course, the essentials of sleep today. We'll also be covering significant disparities that exist as they relate to sleep health. We're going to go over patient and family perspectives on sleep needs. We're going to be talking about behavioral interventions specific for sleep. We'll also have a session specifically on physical medical health assessment and intervention strategies. And finally, we're going to have a session that is really about us. We're going to be talking about healthcare providers and how, certainly if you've seen my past videos before, you will recognize that we are, myself included, are not immune to our own sleep struggles and problems. And so we'll have a session really focusing just on that later in the year. Next slide here. So to kick things off, I'd like to introduce our expert for today, Dr. Todd Wahrenberger. He's a family practice physician and the chief medical officer at Pittsburgh Mercy Health System. He's also the co-founder of the Northside Christian Health Center, a federally qualified health center that serves uninsured and underserved populations in the inner city of Pittsburgh. You may have heard of Dr. Wahrenberger, seen him as he's a frequent contributor to the Integrated Care Dialogue nationally. And he's really been practicing what he preaches for years. I had the pleasure of visiting his clinic actually a few years ago, and I was amazed not only because of just the structure and the inviting layout, but also the sense of community that he's built with his patients who are really at the core of their work. So without further ado, Dr. Wahrenberger, welcome. Thank you for joining us, and please help me sleep better.
Well, I'll see what I can do, Andrew. Again, I'm Todd Wahrenberger. I'm a family practice physician, and I'm the chief medical officer at Pittsburgh Mercy. I don't have anything to disclose. Next slide. And I thought I would start out a little bit by telling you my story, just so you get a sense of who's talking to you. And Andrew gave a little bit of background on this. I am from Pittsburgh. As you can see, it's a city of rivers and bridges. So we have a post-industrial rust belt types of environment. It used to be all steel mills, like in the right upper hand corner. That's a blast furnace that when I was a little kid used to light up the sky in the morning, and it's actually not there anymore. I think there's nothing there along the riverbanks. But Pittsburgh has an old patient population. I think we're the second oldest county in the United States. So, and we also have now moved from industrial steel mills into biotech. We have two very large healthcare systems, and we have three major universities. We also have rabid football fans. So the guy up on the left, if you want to know, is a guy named Pittsburgh Dad. And if you look on YouTube and put in Pittsburgh Dad, you'll see this guy. Steelers are 10-0, so that's a pretty big deal right now. We're looking for positive things in 2020. So Pittsburgh Dad has his terrible towel and, of course, his Big Ben jersey on, and then you can just see in the corner there Mr. Rogers. So we are Mr. Rogers neighborhood here in Pittsburgh. We try to be good neighbors to one another as best we can. So I grew up in Pittsburgh. I was born in Pittsburgh, raised in Pittsburgh, went to college at a little school up in Erie named Gannon University, and then attended the University of Pittsburgh for my medical education and did my residency at St. Margaret's Hospital in family practice. Next slide. So when I finished my residency program, I had a strong desire to work in an underserved patient population. And the two major dominant players, one is a Highmark Allegheny Health Network, and the second is the University of Pittsburgh Medical Center, very large tertiary care centers, transplantation mecca, big training centers. But we didn't really have a really robust primary care for people without health insurance. It was the mid-90s, and the United States, this is before the Affordable Care Act, and so we had a large number of uninsured individuals in the Pittsburgh area. And we knocked, myself and two other residents graduating from St. Margaret's, knocked on the door of the University of Pittsburgh and said, hey, we want to start a healthcare center to try and help people that don't have any healthcare insurance. Will you help us? And we heard crickets. And then we knocked on the door of the other major health system to see if they would help us get a healthcare center started for people without health insurance. And they just flat out said, we don't know what to do with primary care. We're a tertiary care center. We're not about it. And then we knocked on the door of the Sisters of Mercy. Now, the Sisters of Mercy had been in Pittsburgh since the time of the Civil War. And they were founded by Sister Catherine McCulley, who her big reason for starting the order was so that nuns could leave the convent and go out and take care of people that were homeless, children, women, anybody that didn't have a way of providing care for themselves, and to do enabling services. So they had established a hospital in the Pittsburgh area, Mercy Hospital, and they were very interested when they heard our story. They said, this has been our story for 150 years. Heck yeah, we want to help you out. So they helped us to start this federally qualified healthcare center in the inner city. And so I successfully was able to provide primary care to my patients on the north side. So Pittsburgh set up into 4 quadrants. We established this federally qualified healthcare center on the north side of Pittsburgh, and I was the medical director there for 15 years. It became a federally qualified healthcare center when the Affordable Care Act was enacted back in 2008, and led that and started some satellite clinics. The sisters came knocking on my door again in about 2010 and said, we have this other part of our agency that cares for people with severe mental illness and addiction and homelessness. And we think you'd be the perfect person to come and try and build a health center that takes care specifically of that patient population. And in 2010, I said, I don't think I want to do that. I'm happy here at the Federally Qualified Healthcare Center. And so 2 years later, it just kept pressing on my heart that I should try and step more into care for a different underserved patient population. And so the Sisters of Mercy helped us to start a healthcare center that was fully integrated into Pittsburgh Mercy. Next slide. So this is a picture of the south side of Pittsburgh. So I moved from the north side to the south side, which sounds like a big trek, but it's all of a 15-minute car ride to the other side of the point. And so here's our south side. To the right of the bridge is a small campus of 4 buildings that represent Pittsburgh Mercy. The sisters had sold their hospitals off to the University of Pittsburgh in 2008 and got out of the inpatient business and really wanted to go full throttle in serving people directly in the community. So they have a large community outpatient mental health center that services about 20,000 individuals with severe mental illness with an outpatient center. They have a whole alphabet soup of services that we can provide in the community. And so in 2012, I jumped both feet into the world of community behavioral health. So the 4 buildings on our Southside campus house a crisis and recovery center and a diversion acute stabilization unit where up to 30 individuals can stay for up to 30 days. It is a diversion from jail for people with serious mental illness. They can see a psychiatrist and get connected into housing through that crisis center. It's not a locked unit. And our primary care center provides primary care to all those individuals, many of them needing good, robust primary care. That campus also has a large outpatient facility, which has intensive outpatient and partial hospitalization programs, as well as just general outpatient services offered. And then we have a 3rd building that houses 4 assertive community treatment teams and 2 integrated dual diagnosis treatment teams, which as a primary care physician practicing for over 15 years, I had really never even heard of assertive community treatment teams or integrated dual diagnosis treatment teams. I maybe heard about intensive outpatient treatment, but the rest of these levels of care that were provided in the community, I thought were just fascinating and amazing. Many of these individuals would have been chronically institutionalized 20 years ago and now are successfully living out in the community. The building in the very foreground, just before the river to the right of the bridge, is the building that the sisters were able to create for the primary care center. So the first floor is primary care that's fully integrated with the rest of the system. We share electronic health information back and forth, not the same electronic health record, but we can see theirs, they can see ours. We have pharmacy services, and then we have HUD-funded housing for individuals that have chronic homelessness. It's a housing first model that's very, very heavy on harm reduction. We offer medication assisted treatment and I'm very proud of being there for 10 years and watching the services grow over the past 10 years. Next slide. This is my team. The picture's a little bit dated. I used to have a beard, but had to shave it off for COVID. But we have in our primary care center, care managers, peer wellness coaches, medical assistants, medical secretaries. We even have AmeriCorps volunteers, in addition to physician assistants, nurse practitioners, consulting psychiatry for those that won't go into formal services. And then we have primary care doctors in internal medicine. Next slide. And if you walked into our waiting room, the picture to the right would be a picture just showing you who your care team is when you come into the health center. And there's the building there. Next slide. One of the other services we provide is services to homeless individuals. So the picture on the left is underneath one of those many bridges that span the Allegheny, Monongahela, and Ohio rivers in Pittsburgh. And so individuals will have tent cities under those bridges. We have part of Pittsburgh Mercy is Operation Safety Net, headed up by Dr. Jim Withers. He takes teams of volunteers and a small team of people that are hired by the system to go out under the bridges and provide basic medical care, clothing, and try to link them to services like our trailing apartments where they can go and get off the street. So a lot of it's built upon building trust over time with individuals. The individual on the right is a fellow who got into trailing apartments. I had the pleasure of being able to take care of him for a couple of years before he was diagnosed with unfortunately cancer. But he didn't die under one of these bridges alone and in the dark. So it's kind of powerful stories that you hear about being able to engage with people and get them to a higher level of care. But definitely it was just an honor to be able to treat some of those individuals that have been forgotten over the years. Next slide. So I told you a little bit about myself as a primary care physician. It would be great to hear who my audience is today. And so there's just a couple of questions here to ask where you work and who's in the audience today that I'm addressing. I might try to focus my talk a little bit more depending on who's in the audience. We'll just give folks a second to vote. Hope everybody got a good night's sleep last night so you can stay awake for this presentation. Super important. Okay, so most folks, half the group is in a behavioral health setting and a third in integrated care settings. That's great. We have a nurse practitioner, registered nurse and therapists in the audience, social workers, and some listed as others. Great. Next slide. So we hope to talk about the impact of sleep. This next poll is asking, when did you sort of figure out that sleep was important? Was it, sleep's kind of just getting turned on to it in school, in your residency, because it's a big patient complaint, or from a broader field of networks? Oh, that's right. The Steelers did win last night. So most people in training and in school, and because of patient complaints of this. Great. So just sort of setting the stage around why sleep is important. I really do tend to think about sleep in three different categories. There's sleep the same way we think about brushing our teeth and wearing seatbelts and exercising every day and doing those general things that are good to keep us well and healthy. I think about sleep as a pathology when I think about things like chronic insomnia, obstructive sleep apnea, people that have problems with parasomnolism, sleepwalking, hypersomnia, and then people that uh, as a pathology that we could diagnose from the Diagnostic and Statistical Manual. And then I think about sleep as we don't get enough of it and we're just tired all day long. So I think about daytime drowsiness when I think about sleep. But sleep is a super important topic. Next slide. And we're hoping to just give you a basic awareness here about why sleep is important, and lack of sleep is a huge problem in industrialized nations, and point out the harm to our society in general and to us as individuals for chronic insomnia, and a bit of a differential diagnosis to sort of carry around with you to work on excessive daytime sleepiness, and then describe the diagnostic criteria around insomnia, which is the most common. Chronic insomnia, not acute insomnia. Next slide. And then some of our takeaways is, again, sleep is integral. It's not incidental to good physical and mental health, and that we really should think about treating difficulties with sleep and insomnia as an entity unto itself, not just a side effect of medical problems or psychiatric problems, because there is a push and a pull here with insomnia. It's both a symptom, and it also creates a lot of problems. It's a driver of other symptoms. And that we should be screening a bit more for sleepiness and lack of sleep. And we can use a tool I'm going to introduce you to called the 3 pillars of healthy sleep to help to target the diagnosis and treatment. And that our current pandemic, and I really will talk a little bit about the COVID-19 pandemic, but I don't know about you, but it's nice to be on a talk where we're not going to talk exclusively about COVID-19 as we get a lot of that nowadays. But it has been exacerbated by the COVID-19 pandemic. But we do have treatment options and recommendations. Next slide. So why this matters. Next slide. So the National Institutes of Health and Medicine in 2006 published Sleep Disorders and Sleep Deprivation, an Unmet Public Health Need. This was sort of the first one. There's been subsequent ones even as late as 2020, listing 50 to 70 million Americans suffering from disorders of sleep, and that it has a definite impact by increasing risks of diabetes, hypertension, obesity, depression, heart attack, and stroke. These are all bread and butter in primary care. We see them all the time, and lack of sleep is definitely impacting those things. The World Health Organization has declared sleep loss an epidemic, not a pandemic, because it seems to be a bigger problem in industrialized nations, with about 10 to 15% of people worldwide suffering from chronic insomnia. And then the CDC, again in 2016, reported out that a third of the US population was not getting enough sleep. And if we do surveys in general primary care, if we take the time to ask our patients about their sleep, they will self-report or report to us 50 to 80% of the time that they don't sleep well. So it definitely is a huge problem. Next slide. So coronasomnia, this is a term that's been put out since the start of the pandemic, and looks like it really started to ramp up in May and in June when the pandemic started really pressing in on people. And it's an increase in the sleepiness of our general population and a problem with insomnia that's thought to be due to the stress that comes from the pandemic. And so we have money problems, we got kids at home, we have a lack of the ability to interact in a normal fashion with other people. A lot of us are working out of our home. Right now I'm working this afternoon anyway, out of my second floor of my house, not in my bedroom. And then there's just been a lot of upsetting news over the past year, and it's nonstop. There's a lot of uncertainty about the future. We at least have the promise of a vaccination coming that may end the crisis, and at least, you know, the election's over, but we still have a lot of problems, and it's not really certain when that's going to end. But you know, hyper arousal is a normal way to compensate. Our bodies compensate when we're faced with danger. It would be really bad if, you know, you were walking in the forest and there was a bear chasing you and you went to sleep. You're supposed to be awake whenever danger is around. So it's adaptive and protective for us to have this difficulty with insomnia whenever we're having problems like this, heightened stress like this. Unfortunately, it's happening over a prolonged period of time. Next slide. So this is from the Kaiser Foundation that looked at the adverse effects due to worry and stress related to the coronavirus. So half of all people are having adverse effects from worry, and a third of that worry is problems with either falling asleep or sleeping too much. And then if we look at things like appetite, irritability, trouble controlling our temper, headaches, increasing with alcohol and drug use, and then worsening of chronic conditions, we certainly see that all of those things, the appetite, temper, headaches, stomach problems, can all also be related to not getting enough sleep. And this was done back in July. This was just a poll that was done by the Kaiser Foundation. Next slide. And we know that sleep impacts individuals differently. Poor sleep is disproportionately impacting ethnic and racial minority populations. Those folks have already been under it. Caregivers, people with underlying serious mental illness, we know that the pandemic already affects them even more heavily. I'll tell you, I've seen this firsthand in some of our group homes. We have 90 group homes scattered throughout the county for people with severe mental illness, and our staff that cares for them are from minority populations predominantly. There are some folks that are from the Bhutanese community and certainly African American community caring for individuals, and they're under a ton of stress right now and having problems with sleep. They're working a lot of shift work, and they are essential workers. And so it really has a negative impact and definitely is part of social determinants of health. Next slide. And then this is just a big study that was just published last month by the Lancet Psychiatry, a bidirectional study, over 62,000 COVID-19 cases out of electronic medical record data. And so this is pretty big numbers. But when they really looked at COVID-19 survivors, and this is again part of Coronasomnia, they had a significantly higher rate of psychiatric disorders, dementia, and difficulty sleeping, insomnia. And they also saw that if you had a mental illness, a psychiatric illness, it was an independent risk factor associated with an increased risk of getting COVID-19, and that rates of insomnia diagnosis have been markedly elevated in agreement with predictions that COVID-19 was going to definitely interrupt circadian rhythm. And we'll talk about what a circadian rhythm is and some of the latest thinking around circadian rhythms. Next slide. So I saw in the previous survey, it looked like somewhere around 15 or 20% of us have noticed that our patients have complaints of difficulty sleeping, which have caused us to maybe want to listen to this talk. Do you think a lack of sleep impacts the patients that you serve right now? I'll just give you a minute to finish that. Yeah, so a lot or quite a lot, most of us see. You know, what's really super interesting is, at least I know in primary care, people come in because of a problem like pain or a problem like high blood pressure or their diabetes, and they might have a list of 5 or 6 or 7 things that they want to pay attention to, and it's always the last one is, I'm having a bugger of a time sleeping. Can you prescribe me a sleeping pill? But it's always in there, right? But it always ends up being the cherry on the top at the end of the visit. Next slide. So this is just a case study. Actually, this isn't a very typical patient of mine, but I think it highlights coronasomnia. So I thought I would give this out as food for thought. SG is a 68-year-old patient of mine. I've been taking care of him for 20 years. He has a history of high blood pressure. It's well controlled. He gets a gout flare maybe once every 18 months. But he came in specifically because he was having a really hard time with his sleep, both falling asleep and staying asleep. He works as a motivational speaker. And prior to the pandemic, he had a busy job. He was traveling a lot. He was in Europe. He was in Southeast Asia. He was in Hawaii. He was in California. And then, he's East Coast based. So he was doing a lot of traveling, and his business had to change over to Zoom meetings, which he found very difficult, sort of managing the technology, and thought that was a much more stressful way to do things. And in his travel in the past, he'd been used to using Tylenol PM to help himself get onto the local time zone and then to get back to Eastern time zone. So he found that medication pretty effective. So when he started having problems sleeping in March and April, he started using either Benadryl or Tylenol PM every night. And so Tylenol PM is acetaminophen and Benadryl, diphenhydramine. And he just was like, it's just not doing it anymore. I'm still having trouble falling asleep and I'm having trouble staying asleep. So the next question is, what would you do for SG, a 68-year-old gentleman who comes in and he says he's kind of concerned he's depending a little bit too much on the Tylenol PM and it's not even helping him anymore. Would you give him some Zolpidem, Ambien, and move on to the next patient because you got a busy afternoon? Would you do a history and physical examination on him, targeting questions around his sleep hygiene? Would you review his medication list for both prescribed and over-the-counter medications and try and see if that could make an impact on him? Or would you do 2 and 3? Okay, so it's a smart group. 2 and 3 is correct. That's what I would do. And we'll talk about as we move along here why that's so important, and maybe some tips on doing it more efficiently during your visit and getting a history on his sleep. Next slide. So why we sleep, I'd like to talk about sleep from why the heck do we sleep from an evolutionary standpoint, maybe from a standpoint of where we judge people for sleeping too much or not sleeping enough, how it impacts our mental health, our physical health, why it's so important for optimal memory and creativity, and what does exactly happen to us when we're asleep. Next slide. So sleep as an evolution, when we think about evolution, sleep is idiotic. So Matthew Walker, PhD, if you really want to get a really good read, so Matthew Walker wrote a book called Why We Sleep, and he is a PhD researcher from UC Berkeley. He's given a number of TED Talks on sleep, and he would say sleep is idiotic. It's not protective at all to sleep, because if you spend a third of your time unconscious, you're not gathering food, you're not protecting yourself, you're not moving ahead, you're just unconscious. So from an evolutionary standpoint, it makes absolutely no sense that humans should sleep, because it makes us very vulnerable, right? But he also notes that all animals need to sleep. So if we look at all animals, even insects need to sleep. To some varying degree, they all need to sleep. So I thought this was fascinating. Elephants need 4 hours, humans need 8 hours, tigers and lions need 15 hours, and bats need 19 hours of sleep to get to be healthy. We spend a third of our lives sleeping. So he concludes that if everyone needs to sleep, somehow, some way, this must be a very important thing. And he also notes that humans are the only species that purposely deprive themselves of sleep, and this causes negative physical and mental health complications. To the best of our knowledge, when you deprive an elephant of sleep, it doesn't have those negative physical and mental health complications like it does in humans. So it's kind of fascinating. Probably has to do with the fact that we have really big prefrontal cortexes. Next slide. So your sleeping pattern, what best describes your sleeping pattern? So we have Those of us that are night owls, and they do best in the evening, and they like to sleep in a lot in the morning. And then you have people that are morning larks. They get up early and they're ready to go, but they fade fast late at night. And then some of us are somewhere in between. We're sometimes a night owl, sometimes a morning lark. We can kind of go either way. Some of us are connecting with bats, I see. That's good. I feel batty sometimes. Okay, so this is really fascinating. It looks like about a third of us are night owls, a third of us are morning larks, and yeah, a little bit over a third of us are somewhere in between. Next slide. So if we look at sleep and moral judgment, this is a nursery rhyme from Grimm. Grimm was kind of wrote a lot of interesting things like, hey diddle diddle, the cat and the fiddle, the dish ran away with the spoon. Nature needs 5, custom needs takes 7, laziness takes 9, and wickedness takes 11. And they're talking about sleep here. So definitely casting a bit of shade on people that sleep too much. And then the quotation, early to bed, early to rise makes a man healthy, wealthy, and wise, attributed to Benjamin Franklin a lot, but it was first listed in Poor Richard's Almanac, and probably was something that Ben Franklin said an awful lot. But definitely historically, we tend to look with a little bit more judgment on people that either sleep too much or tend to be night owls. Next slide. So in a way, we can't help it. We are wired, our bodies, our circadian rhythms, our internal sleep drives are genetically wired into a rhythm. And you can't really choose your circadian cycle. So those of you that said you were a night owl, and those of you that said you were a morning lark, and those of you that said you were somewhere in between, that would hold true generally for the general population, that a third of us are night owls, a third of us are morning larks, and a third of us are somewhere in between. But our society does tend to paint people as lazy, and our standard employment schedules are really very heavily weighted towards getting up early in the morning and doing our jobs. But I would ask the question when we look at this is, could there be an evolutionary advantage if we are a species that does really well living in community, even if they're just small groups of people, and we go back 10,000 years and humans did much better when they were able to be in tribes of groups of 50 or less. If a third of your group likes to stay up late and a third of the group likes to get up early in the morning, then it kind of makes sense that some people can be watching out for danger while other people sleep, and other people can get up early in the morning and watch out for danger while the night owl sleeps. So it kind of makes sense that we're all sort of wired to sort of go in between these circadian rhythms, because it protects us, us as a species on the whole. Next slide. So insomnia and mental health, we all sort of have a sense that sleep is strongly associated with psychiatric diagnosis. And there is a strong association with insomnia and depression, anxiety, and alcohol use. So this is a little bit of an old study, 1996. They looked at close to 1,000 individuals and looked at pre-existing a subset of the group, about 240, suffered from insomnia at the beginning of the study, but did not have problems with depression, anxiety, substance use disorder, and then try to match them to people without insomnia for age and other demographics. And then they followed them over 3 years of time. And the group that had problems with insomnia, although at the beginning of the study didn't struggle with these problems, over time started to develop worsening problems with depression, anxiety, and substance use disorder to a much greater degree than people that were able to sleep at night. So insomnia, this hyperarousal condition. Next slide. So really looking at, and this is with my primary care brain, just trying to break the brain down into 3 different levels: our brainstem, our midbrain or our limbic system, amygdala, and then our higher brain functions, our neocortex and prefrontal cortex, executive functioning, emotions, memory, and then brainstem survival functions. And these levels all go back and forth, and they have pathways to be able to communicate super effectively back and forth. But really our brainstem is working on answering the question all the time, am I safe? Is everything okay, right? It's regulating all of our body function. It's making sure our blood pressure is okay. It's making sure our oxygen levels are okay, all those good things. And if it can answer those questions, I'm safe, I'm okay, then we can go up to the higher levels of function, like, am I loved? Am I understood? Do people get me, around me? And do I feel some sense of emotional security in my life? And then if those two questions are good, I'm safe and I'm loved and I'm understood, then I got lots of time to move off into my prefrontal cortex and do executive functioning, like, what can I learn? What can I reason? What can I see about my environment? And then I can use that information to answer questions 1 and 2. I'm safe and I'm loved and I'm understood. It turns out when we deprive humans of sleep, and this gets back to maybe why bats and lions and elephants don't suffer so much when they get sleep deprived. When we sleep deprive individuals, the communication pathways between our prefrontal cortex, our executive functioning, and then our emotions and memory in the limbic system get interrupted. And we can see this on functional MRI scans. And so people get super irritable, right, when they're sleep deprived. They make bad decisions, they make impulsive decisions. And so we can see why this would have a definite impact on our mental or emotional well-being when we can't get enough sleep. Next slide. So sleep and physical health. Again, the NIH came out in 2020 saying heart disease, kidney disease, high blood pressure, diabetes, stroke, obesity, chronic pain, and even Alzheimer's disease are all very negatively impacted by having problems with sleep. But we also know that when we don't get enough sleep, we're more prone to injury, we're more prone to falls, we're more prone to twisting our ankle when we're out on the soccer field playing. The picture up to the far right, motor vehicle accidents are very strongly associated with not getting enough sleep. We have these, you just fall asleep for a second, for a microsecond, and you make a mistake while you're driving and you can have an accident. At the bottom right-hand corner, we see that there's been a number of large industrial accidents. So this is 3 Mile Island. It's about 200 miles to the east of Pittsburgh. That accident was thought to be secondary to sleep-deprived workers in the plant was a contributing factor. Certainly the Challenger disaster, Bhopal, India, a number of other accidents have been attributed to sleep deprivation in people working in those industries. And then, of course, medical personnel. So the picture of the scissors in the chest x-ray. So I trained in a time where residents were not given regulations around how many hours they could work. So they could pretty much work you 100, 120, 130 hours a week, and you could be up for 36 hours on end. And this was seen as, for doctors, as a badge of honor, that you could stay up for 36 hours and take care of your patients, and this was a good thing. But we learned that the rate of medical errors go up the more people have problems with their sleep deprivation. And fun fact, one of the founding doctors of medical residency programs in the late 1800s was a Dr. Halsted. And so he was at Johns Hopkins sort of setting up the initial precursors to the training programs we have right now for medical doctors. And he sort of really made sure that his medical residents were very good at staying up late and could work many, many hours. And so he was sort of famous for really grinding that into the culture of residency programs, which sort of spread throughout the United States. It turned out that Dr. Halsted was also a cocaine addict and had to go through a lot of rehabilitation to get off cocaine. So there may have been a reason why he was sort of famed for all of his stamina. Just a quote here again from Matthew Walker: the shorter you sleep, the shorter your life. Not only does it take years off your life because of chronic disease, but it also takes years off your life because of trauma and disasters that can happen. Next slide. And then there's a lot of data out there about sleeping optimal for function, for your memory, for your creativity, for your physical performance. If we look at your non-REM sleep and your REM sleep conditions, they're thought to be very important in consolidating memories, both old memories and learning new memories and incorporating them, and that REM is really a good place for you to be able to understand strong emotional reactions. The Journal of Pediatric Orthopedics did a study in 2014 looking at sports-related injuries and sports performance. And then the NBA, who's done a really good job during the COVID pandemic, it looks like they like to really base a lot of medical science around their players. Did some studies around sleep, and that players that got more than 8 hours of sleep played a lot more, and they scored a lot more, and that players that weren't able to get 8 hours of sleep fouled out a lot, and they had a lot of turnovers. So the NBA is really has a good understanding of its importance for peak physical performance. Next slide. So I'm just going to go into a little bit about the stages of sleep. This may have been something we don't think about a whole lot because it's not always directly important to understand the stages of sleep for what we do functionally in primary care. But basically, we know this information because of electroencephalograms and sensors on a polysomnogram. And so the graph to our right depicts a normal sleep cycle over 8 hours. We typically start out sleep by falling right into a deep non-REM sleep cycle, and then we get less NREM as the night goes on, and then we're more and more in REM. So REM standing for rapid eye movement, which is irregular conjugate eye movement, and it represents about 20% of our sleep. We really think that we need both non-REM and we need REM sleep. REM is really important for memory, and sort of pruning out all those details we don't really need, that aren't really important. It's also a safe place to be able, when we're dreaming and having all these emotional dreams, our car is in neutral, so our bodies don't, when everything's functioning properly, our bodies don't tend to take a walk or run or scream. We're able to process those memories in a safe environment without a lot of noradrenaline around. When we're in non-REM sleep, that's probably what's important for learning fact-based information that you might read from a textbook. So the last thing you read before you go to bed at night, falling into an NREM state, there may be some evidence behind that because of it. And NREM induces, is really induced by adenosine. So when we see this big adenosine drive building up in the brain during the day, it hits us pretty hard into NREM sleep. But it's also where sleepwalking happens when we fall into NREM sleep. So most people think we go sleepwalking when we're in REM sleep, when we're dreaming. It's really in the NREM stage that we get that. And so to the right are sort of the physiologic features and what the EEG pattern looks like. But basically, a lot of this stuff is theory. Restoration, energy conservation, memory consolidation are all thought to be theories about what we sleep, but it's still largely understood why we need to sleep. We just know if we don't get it, we don't do well. Next slide. So the other key thing to remember is insomnia is just, it's not the same as sleep deprivation. So when we think about people, when you have insomnia, you're wide awake, you're laying there and you cannot fall asleep, which is different from people that have jobs where they're working 3 shifts or they're working long hours. I think about residency, when you're having to actually be sleep deprived, you feel tired all the time, but they're not the one and the same. Next slide. So if we look at the diagnostic criteria from DSM-5, we really know it's the chronic insomnia is something that occurs over at least 3 months, and it's 3 nights per week. And it's a problem with falling asleep, staying asleep, or waking up a lot in the morning. And really the patient really needs to say that they're really unhappy with the amount of sleep they get or the quality of sleep that they get. They can't sleep despite the opportunity to be able to sleep. So again, if you're a resident in the hospital, you might not be given a lot of opportunities to sleep. That's different than with insomnia. And typically you'll see insomnia patients, their eyes are wide open when they're laying in bed, as opposed to people that have problems with daytime sleepiness, who are usually have their eyes very heavy. And also, we've kind of ruled out medication, substance use, medical conditions, and psychiatric conditions. Next slide. This is other criteria that's from the medical side of things instead of the mental health side of things. So this is from the sleep medicine doctors, and their criteria are picking from a menu of A, B, C, D, E, F. But basically, it's the same thing. It's despite the opportunity to sleep, people can't sleep. It's happening over an extended period of time, and there's really no good medical reason for why they're not able to sleep. Next slide. So oftentimes patients will come in asking for a sleep study, or will think, what can we do to try and diagnose what's going on with the patient? Maybe we need to get a blood test on them. Maybe we need to get some sort of diagnostic study on the person. So a polysomnogram, again, is where we're doing sensors and doing an EEG, and we're measuring oxygen level and breathing. Very, very helpful if we think that the patient is struggling with obstructive sleep apnea. Humans are very susceptible to obstructive sleep apnea. We have problems with our upper airway. The thing that allows us to speak so well is a nice flexible upper airway. Most animals they have a much more rigid upper airway structure, with the exception maybe of dogs. My dog snores sometimes, but humans tend to snore a lot, and that will deprive them of proper sleep, and people will complain about either waking up frequently at night or feeling tired during the day. Cheney-Stokes breathing is associated with congestive heart failure, and a polysomnogram is pretty good at picking that up. In addition, if you have underlying respiratory conditions, lung conditions, restless leg syndrome or periodic limb movements, parasomnias, and narcolepsy can all be diagnosed by polysomnogram. But people just coming in straight up with a complaint of insomnia, I can't sleep at night, a polysomnogram is not super helpful in diagnosing them. Next slide. So what about using screening tools, just giving somebody a screening tool? Well, there is a Pittsburgh Sleep Quality Index put up by Dr. Busis. I sometimes am able to actually refer patients to him. He's kind of famous sleep researcher at Western Psychiatric Institute. But the Pittsburgh Sleep Quality Index is kind of a long, lengthy tool, hard to use in practice and good for research. So is the Sleep Problem Questionnaire Calculator, which you can get online. And there's a link at the end of my talk about how you can use that questionnaire electronically. But most of the time, these screening tools that you would hand patients, like a PHQ-9 test or a GAD-7, aren't super duper helpful because most of them have been created for research studies. Next slide. What is helpful is to try and think about, when you're talking to your patients about difficulty with sleeping and insomnia and feeling tired all the time, is the 3 pillars of healthy sleep. So really looking at, are they getting the right quantity, the right amount of sleep? Are they getting the right quality of sleep? And is the sleep at the right time? So just trying to keep those in mind as you're talking to people: timing, quality, and quantity. Next slide. So in terms of quantity, average sleep in US adults, according to a 2013 Gallup poll. How much sleep do US adults get on average during the weekdays? And I really put these questions in here to keep you from falling asleep during my talk. So yeah, this is smart audience. 6.8 hours is what we're getting on the weekdays. And what we're really getting on the weekends is about 7.4 hours. So 40% of adults are getting less than 7 hours of sleep on weekdays and 7.4 on the weekends. By the way, it really doesn't work that way. You can't really catch up on your sleep on the weekends. That's not how it works. It's the consistent sleep that you're averaging over time. And so this idea of a sleep debt that you catch up on the weekends is a little bit been debunked. Next slide. So the right quantity depends on how old you are, but for most of us that are adults, from 18 years of age, even right up into advanced age, really we're needing more than 7 hours of sleep a night. And most literature would suggest that it's a very rare individual, like 1% of our population, that can really optimally function with less than 7 hours of sleep per night. It's very unusual. As you can see, newborns, infants, toddlers, they get a lot of NREM sleep. They get really deep sleep. If you watch a toddler sleep, they're just completely limp. And then that tends to get, we tend to get less and less NREM sleep as we get older. Again, both of them being super important, but this sort of myth that when you're older, you only need to sleep 4 or 5 hours at night has been pretty soundly debunked. You still need a good 7 to 8 hours of sleep. Next slide. So if we're looking at quality of sleep and people that are really struggling, if you really just think, most of the problems with quality of sleep, like the lion's share of it is obstructive sleep apnea and the patients that we struggle with. But there's a lot of other things that can lead to difficulty with quality of our sleep. Restless leg syndrome is a big one, especially people that complain that they never have this problem until they go to bed, and then they go to bed and they feel like their legs need to move. And as soon as they get out of bed and they start walking, the sensation that they need to move their legs, it completely disappears, and it's really keeping them from being able to get good quality sleep at night. We know that from a mental health standpoint, that depression and bipolar, certainly substance use disorder and withdrawal of substances, including caffeine and alcohol, can play a major role in the quality of our sleep. There's been some good studies on post-traumatic stress disorder and having problems with REM sleep and having a disconnection, again, probably between our higher prefrontal cortex and our limbic systems, our amygdala, having some interruptions in the connections there related to post-traumatic stress disorder and anxiety, probably one of the most common psychiatric causes, generalized anxiety. For the internists in the group, congestive heart failure patients will have a hard time sleeping, certainly if they're having angina or problems with palpitations and arrhythmias while they're sleeping at nighttime, can be a tip-off. I know that even if I go to a high altitude place, when we go to high altitude for the first few nights, our heart rate tends to go up a bit. Just those palpitations that you get from increased heart rate of being at high altitude keep you from getting a good night's sleep. Next slide. And then things like gastric reflux, inflammatory bowel disease, irritable bowel disease can all be, reflux. A lot of patients complaining, I wake up in the middle of the night and I have reflux problems. It's interfering with my sleep. From a pulmonary standpoint, our oxygen levels dropping from COPD or having an asthma exacerbation in the middle of the night is quite common. I've never met a pregnant woman that didn't have at least a smidge of a problem with the quality of their sleep, especially in their third trimester. And menopausal women will frequently have complaints of hot flashes in the middle of the night, interrupting their quality of sleep. So helpful questions to ask. Next slide. And then from a neurologic standpoint, sleep is a brain problem. And so if you're having things like Alzheimer's disease or Parkinson's or traumatic brain injury, it's really going to affect your ability to get into the NREM and REM cycles. Certainly chronic pain and neuropathy will have problems. So if patients' pain is not well controlled, they will not sleep well at night. From an endocrine standpoint, we always think about the thyroid disorders and then diabetes. Diabetes just by itself, not even the polyuria, polydipsia stuff that you have from high blood sugars, but diabetes just by itself can play havoc with our quality of sleep, even more so if it's not well controlled. And then problems with renal failure, people that get up a lot at night to have to go to the bathroom or have problems with incontinence. Next slide. A lot of this I'm going through kind of quickly. In future presentations, we're going to go into this more in depth around the medical complications and certainly medications. It's kind of a no-brainer if we diagnose people's methylphenidate right before they go to bed, they're not going to be sleeping so well. I've gotten calls from patients in the middle of the night, very anxious after doing some cocaine, and then caffeine is the big one. Interesting fun fact, we all tend to metabolize caffeine at different rates. Some people are fast metabolizers, some people are slow metabolizers. So your friend that says, I can't have caffeine after in the afternoon because I can't fall asleep, they're probably a slow metabolizer of caffeine. Caffeine is, it really tends to block that sleep drive for us that builds up in your brain. It's an adenosine blocker. As you get older, you tend to metabolize it slower and slower. So as you get older, you can't have caffeine after a certain period. So when people start drinking more decaf as they get older, don't cast too much shade on them. It's not their fault. Some of the older antidepressants that we used to use, the tricyclic class, were great side effects for helping people to sleep, but the newer ones, the SSRIs and the SNRIs, and certainly Wellbutrin, bupropion, when they're dosed later in the day, can play havoc with people's sleep. And then cardiac medications, we're always looking at herbal medications that patients could be taking. I see a lot of people with St. John's wort and ginseng having difficulty sleeping at night. I always warn my patients, if I put them on prednisone or a steroid, it can play havoc for a few days with their sleep. Theophylline is not a drug we use very much nowadays, but definitely is a stimulant. Then the over-the-counter decongestants, and the big ones are really alcohol, nicotine, and caffeine to talk with your patients about on a regular basis, because they're just so ubiquitous and can play havoc with sleep. Alcohol, particularly with your REM sleep, it can deprive you of REM sleep, which is super important. Next slide. So, and then getting back to the third pillar, the right timing, and just to talk real briefly about circadian rhythm timing. It's our intrinsic timekeeping system. It has to do with an interplay between our reticular activating system and our hypothalamus, and then this sleep drive that we have. It operates over 24.2 hours per day, so it's not quite on a 24-hour clock, and it regulates our temperature, cortisol, and our appetite. Again, it's kind of this homeostatic system that is battling against a drive to fall asleep as we're awake. And we have to have something to cue us to a 24-hour time clock. We call those time cues Zeitgebers from the German, or Zeitgebers. And probably the most important one is our light-dark cycle, or sunlight and then darkness. We think that the photoreceptors in our retina are very sensitive to blue light. There's a lot of literature out there about us looking at little screens all day long, and then late into the evening, really impacting that cueing mechanism. The release of the melatonin from our pineal gland. And that really, melatonin is not a sleeper by itself, by the way. It's a cue. It tells your body it's time to go to sleep. And so it's important in that sense. And so if light and dark is upsetting the cue of the melatonin, it's going to play havoc with our circadian rhythm. Next slide. And I really like this slide because it depicts our wake-sleep cycle. So if we really look at somebody that wakes up at 9 o'clock in the morning and they go to bed at midnight, you're waking up at 9 o'clock. And most of us, when we wake up, we're not really ready to go for an hour or so until our alerting signal, our circadian drive coming out of the reticular activating system really starts to build up, and then we become fully awake. And you see there's this sort of siesta time about 3 o'clock where our wake starts to dip down as our sleep load starts to pick up. And then we get our second wind about 8 o'clock in the evening. And then our circadian rhythm starts to go down, the sleep load starts to back off as we start to metabolize the adenosine that's sort of built up in our brain all day long. Incidentally, my patient that was taking the diphenhydramine tends to blunt the alerting signal. So that makes you fall more rapidly into sleep. And caffeine tends to block adenosine, so your sleep load starts to back off when you take too much caffeine. So that's how those guys work. Next slide. People ask all the time about actography, which is really looking at these little devices we wear on our wrists and trying to understand whether they can help us tell us if we're getting good sleep at night or not. There are medical graded ones that you can get in a sleep lab. I've not really recommended them to patients. They have been rated for and validated when they're given to somebody that are medical grade, but the ones that we get are iWatches and our Fitbits. really have proprietary algorithms. So I don't put a lot of weight, although I get a lot of questions from patients asking about what does this mean about my sleep. The best way to be able to measure how well somebody's sleeping is to do a sleep log. And we're going to just talk about that real briefly next slide. So this is a sleep diary. This is probably a better way for two reasons. One is it gives your patients something to do to help them focus on their sleep hygiene. They should do it over a 2 or 3 week period of time. There's a link at the end of the talk that'll take you to this PDF file so you can print this off for your patients. There's a sample at the very top of this graph. And so you're really looking at blackening in the squares where you think you slept last night. And it's actually pretty accurate when people sort of can estimate the hours that they slept, the hours that they maybe napped. And so if they're napping, that might be having a negative impact. When did they have any alcohol? When did they have any caffeine? When did they take some of their medications? And so this does a couple of things. One is it educates the patient on their sleep. It's very informative. They're like, oh, I do a lot of napping, or, oh, I do take caffeine at this time of day, or, oh, maybe this medication's having a problem. And it's also instructive to you whenever the patient brings it back to you. So sleep log, probably more helpful than people spending a lot of money or paying a lot of attention to their watches or their Fitbits. And so this can sometimes also speed up the visit, because when they complain about insomnia and not being able to sleep, you can give them the sleep diary and say, why don't you fill this out and come back in the next time, and we'll talk about this specifically because we want to get this right and we really want to understand what's going on. Next slide. So how do we help? Again, future talks are going to be a lot about treatment of insomnia, but it's really two big realms: cognitive behavioral therapy, sleep hygiene, stimulus control, relaxation therapy, cognitive behavioral therapy for insomnia, and really less about using the benzodiazepines and the receptor agonists, melatonin, antidepressants, and all the other things. Tend to be really good for acute anxiety, not so good for people that are struggling with chronic anxiety, insomnia, the pharmacologic remedies. Next slide. So taking action, where do we go from here? If we get back to our case, most likely SG was struggling initially with insomnia that was probably related to his circadian rhythm, right? Being interrupted from all of those time zone changes, and then probably from the stress of having to change his business platform over to a remote one, and then probably having problems getting a little bit hooked on diphenhydramine. Would we send him for a sleep lab study? Probably not. We'd probably want to go through and ask him about snoring and about frequent wakening, maybe use an Epworth sleep scale. I've listed that at the back. It is a tool to be able to look at sleepiness during the daytime and give you some sort of idea. We'd probably want to go through how much sleep is he getting, how good is the quality of his sleep, is he going to sleep at the same time every night and trying to wake up every night, maybe give him a sleep log. And talk to him about the effect that the pandemic may be having some of his worry, maybe trying to not look at his news feed so much all the time, and certainly talk to him about cognitive behavioral remedies. A lot of patients catastrophize around their sleep. They feel, I have a patient that really has a strong belief that he has fatal insomnia, and which is a super rare condition. And he's had it now for 7 or 8 years. So I'm pretty sure he doesn't have it, because it probably would have killed him in the first 3 months. But he really feels like he has fatal insomnia. So sort of dispelling catastrophization in our patients is a good thing. Next slide. So probably key here, and we're going to get to this again in future talks, is looking at your relationship with sleep, because I think if we walk the walk, we can talk the talk. In relation to our quality and timing and quantity. I know even just preparing for this talk, I started looking again at how I was doing with my sleep, and I could be doing a better job. And I think I could have better optimal function if I got better sleep. And we're heading into probably the worst part of the pandemic in the winter months. Are there ways we can be taking care of our patients by talking to them even just a little bit about how sleep's impacting their chronic medical illnesses, their chronic mental health illnesses, and perhaps even maybe causing them to have more accidents, and really adding questions around insomnia and sleep to our differential diagnosis a little bit more. Next slide. And then again, looking at long-term sleep hygiene, I just sort of listed some of the big ones here. The biggest one probably to highlight is keeping a sleep schedule routine, trying to go to bed around the same time so we can just get that circadian rhythm lined up properly. So if we go to bed, at 10 o'clock every night and we wake up at 6 a.m. every morning, and we don't try and vary that too much, will really help us to get into a better regular rhythm of sleep. I personally started lowering the temperature in my bedroom to 65 degrees, and I found that that's been a marvelous help in helping me to sleep better at night, and trying to exercise more in the morning. Next slide. These are just a listing of some of the tools and resources. If you can check out any Matt Walker TED Talks, I think they're well worth the time. There's the sleep calculator there, and then so you can run through the Epworth sleepiness scale to try and gauge that for your patients. And I think that's about it. We're a little bit over an hour here.
Great. Thanks, Dr. Wahrenberg, and folks.
Oh yeah, I wanted to talk about my dog. Yeah. This is my dog Scout. I don't think she's going to make an appearance here, but I'm always really jealous of how well my dog could sleep. And then I found out, well, animals, and particularly dogs, need to sleep like 16, 17 hours a day. So she's just doing her thing, right? But she can sleep anywhere. And I think my dog's going to outlive me because I don't sleep nearly enough for anything. But super great to have pets in your life. So I highly recommend them.
Yes, and normally actually my cat would be sleeping right here next to me.
Right.
Thanks, Dr. Wahrenberger. I think it was excellent. I think certainly in the chat we've got a lot of folks really relating to what you've been covering here and interested in more. So we do have this time now for some extended question and answer, which I think we're happy about. And actually, as we're doing that, Jaime, we can go ahead to the next slide and just show our contact information too. I know some folks aren't able to stick around. So Dr. Wahrenberger, bunch of questions and they're still coming through. One of them, curious, what you've heard around or what you've done around involving peers and peer support specialists, folks with lived experience around sleep. If you have, there's a specific question around, for folks who are engaged in peer support activities, would that somehow impact, like the limbic system effects, or just generally help them sleep better? Have you heard anything about that or seen anything about that?
I know our peer wellness coaches do a lot of work around medication compliance with patients and just talking to them about how they're doing with their medication. So certainly, strategies around dosing of medication during the daytime. They also our peer wellness coaches do a lot of coaching around tobacco cessation, and nicotine being a powerful driver. That sleep log can be somewhat daunting for some of our patients to be able to complete. And I do see a couple comments there. Really having your peer wellness coach learn how to use a sleep log like that and maybe go through that with somebody would be helpful, certainly. Sort of going through how people are doing, how the relationship is with caffeine. So caffeine, nicotine, alcohol, certainly, and the way that they dose their medications would be a really good way to use a peer wellness coach. I usually have my medical assistant help coach patients through filling out the logs, but a lot of, I agree, it is difficult for some patients to be able to complete those kind of logs, and it ends up in the wastebasket and not coming back properly. So I think a peer can really even maybe help go through even just one night of sleep with somebody and learn some interesting information.
Yeah, absolutely. I've seen that as well in primary care, with our peer experts, and yeah, both for addressing the sleep log issues, and there's also others, and we'll talk more about that also in I think our February session on behavioral health interventions specifically. But yeah, using peers to help with logs, but also to just for general engagement. And there is some research that supports their use not only in general, but specifically for insomnia, although I'm not familiar either with specific kind of like what the exact mechanisms are, but it's a good question. Another one that came through sort of big picture, which is interesting, knowing how impactful lack of sleep and short sleep is on mood, medical errors, learning, health. Do you have any thoughts on how we should work to really advocate for policies to be put in place within these systems? This person mentioned like schools starting later and things like that. Any thoughts there? Like, should we be advocating around sleep?
Well, certainly we should be advocating. I know that because of industrial disasters, so now airline pilots, right? We get super annoyed when airline pilots have to, it delays our flight because the airline pilots didn't get enough time away from the plane sleeping. So it becomes a little bit inconvenient when you have to wait for your flight attendants and your pilot to get to the plane. But oftentimes that's because they don't want to have a big airline or aviation disaster. I know I got super irritated when they finally decided that residents were going to have restrictions on how many hours they had to stay up late. And I was like, darn it, why didn't I get that? Kind of thing. But also, I totally agree around children. I think our youngest children do the best probably at getting up first thing in the morning. Teenagers really, that signaling response that happens in the evening, it's really not their fault that they want to stay up late at night. That they have a really strong second wind signaling response that makes them want to stay up later at night. And then they have such a hard time getting up in the morning that anything we could do to advocate with school districts about later start days. But really our culture is very deeply ingrained in a sleep cycle that is not necessarily conducive to where we were 200 years ago. People 200 years ago got a ton of sleep, probably 9 hours of sleep on average before the onset of electricity. But with the industrialized nations, it's become very, very difficult. Homeschooling would be one. I guess if you homeschooled your kid, you could get on a tighter schedule. Yeah.
Yeah, I mean, it does seem like this is an opportunity, as medical experts, as folks in behavioral health field, to really use the information that we have to, to advocate. Interesting, like even the CDC has put out guidance for some later start times, like particularly for certain populations, like children that you mentioned, and yet I know that this conversation has been going for a long time, but perhaps now, again, looking from graduate medical education through schools, it does seem like this is definitely something we should be talking about. Any suggestions? We have a question as far as, sort of the brief initial screening questions that behavioral health providers or others can ask to get at some of this information around sleep. Are there like a few kind of high level questions that we can start with?
Yeah, I think asking people just generally around questions of when you go to bed at night, where do you sleep at night? I mean, I just always start out like, how are you doing with your sleep? Is sleep a problem for you right now? And patients will sometimes shrug their shoulders and they'll say, I sleep about the same as I normally do. And so when do you go to bed and what time do you get up in the morning? Especially if I'm worried about fatigue, if fatigue or daytime sleepiness is a big complaint for them. Certainly anybody that comes in that looks like they may have a floppy upper airway or a large a neck that might be cued in for obstructive sleep apnea. Anytime somebody's treatment resistant to a lot of things, I start thinking like, I wonder if they're getting enough sleep. And so just asking them what their relationship is with sleep, how they do with sleep. Do you get enough rest? Do you get enough sleep? Is my general starting out question with people. But like I said before, a lot of patients will come in, it'll be in their list of problems, but they usually put it down low in their list of problems. And if you're really busy in the office, it can be very difficult to pay attention to it because they're so busy. You're so busy worried about all the other things that are going on.
Yeah, and I think that point, and you mentioned this in the beginning of your talk, that this is one thing that often falls to sort of the bottom of the list somehow, even though it is so pervasive. When you have someone who's coming in and their A1C is just totally off the charts, or they're in physical pain, which I know is another one of the comorbidities you mentioned. That may not be the first thing that they bring up, and yet we know it's kind of sitting there cranking up the volume on so many things.
Yeah. I saw a question there about sleep restriction
Yes.
as a behavioral health strategy. And so sleep restriction is this sort of idea of people that they go to bed and they think, I'm not getting enough sleep, so I need to go to bed earlier, right? So they go to bed at 8 o'clock or 9 o'clock and they want to try it, and they just lay there and they can't fall asleep because that circadian rhythm, that sleep, that wake drive is still going. And so they get super frustrated. So their sleep efficiency is not very good. So if they're in bed for 9 hours, they're only sleeping 4 hours of it or 5 hours of it, and they're getting super frustrated with it. So the idea of sleep restriction is to sort of say, let's look at how much you really are sleeping when you're asleep, maybe using a sleep log or a diary. And if really you're only able to sleep 6 hours, don't go to bed for 9 hours. Let's try and have you wait until later to go to bed. And when you're in bed, that's what you do. You sleep. You sort of normalize. When I hit the bedroom, when I hit that bed, I am going to sleep. And then try to increase those hours gradually over time to sort of normalize that. And get rid of naps. So you're sort of restricting them to be in the bedroom, in the bed, only those hours that they're actually sleeping.
And that is something curious if you've ever run into some hesitance from your patients as you suggest that, like, staying out of bed, not getting to bed, because when we feel, and this came up in the chat too, right? Like you mentioned, catching up on sleep over the weekends, our bodies are asking, they're telling us they're tired, and yet some of the messaging to ourselves and our clients is, no, actually stay out of bed for longer. How do you approach that with people?
I'm sorry. I'm sorry. I was looking in the chat. Say that again.
So for folks who may be struggling with some of the recommendations, particularly around sleep restriction, around staying out of bed, despite the fact that we're feeling kind of sleepy, how do you address that?
I again try to explain to them that the only thing you want to be able to do in your bedroom is go to sleep, and that can be hard if somebody's like in a 1-bedroom apartment, or that's their primary living space. Even sort of setting up that room so there's one side of the room where I live my life, and there's one side of the room where I sleep. So it's just really trying to habituate this idea that you really, bed is for sleeping. You don't go into your bed to read. You don't go into your bed for other things. You really go there for sleeping. But it can be quite challenging. Yeah.
Yeah, and I think this is somewhat related, but it just came up in the questions. What's the scoop on naps? Should we be taking them? Are there any kind of guidelines?
Naps are great. Naps actually have been, they're really, in cultures where napping is really common, is a really good thing. The problem with naps is if you're not sleeping, it's best to get sleep in a continuous block. And so if you're able to get sleep in a continuous block of time, then it's okay to nap. But if the nap is really depriving you of being able to sleep later on, then that can become very problematic for people. But usually when we nap, we don't go into the, we're not napping long enough to go into those NREM cycles and the REM cycles that are in that big chunk. That's why those big chunks are important, because we think that the NREM and the REM together help to consolidate memories, different types of memories and emotions the best. There have been some creative geniuses that have looked at if you can just sleep and wake yourself up in the middle of REM. So when you're napping, you tend to wake up maybe in a little bit of a vivid dream. That sometimes that can spur a lot of creativity. And so people have looked over the years at napping as a way to spark your creativity. I would say that as long as people are having satisfactory big chunks of sleep at night, that napping or biphasic sleep, as they would call it, is a really good thing.
Yeah, and naps are definitely something I have found, with my own patients, we get very attached to naps, those of us who are good nappers. And so that can be something that's just hard, but oftentimes it is like, can we move the nap a little bit earlier if it does seem like if it's, interfering with kind of that larger chunk of sleep. But naps can be quite controversial, it turns out.
Well, and they're judgmental on that too.
Yeah.
Like I have actually one of my partners who's known to go into an examination room and take a nap in the middle of the office. One of my partners, he will do that. He'll go in and take a 20-minute nap, and I'm like, "What are you doing? There's patients to be seen," And he's like, "No, I need my nap." So I'm like, "Okay, he needs his nap. All right." But so he got a lot of he got a lot of dark shade cast on him for that over the years, but I'm more forgiving of him now of that. I don't have a good Spanish resource. I don't know if anybody else on the chat has any good Spanish resources for Spanish-speaking patients for sleep.
Yeah, I have to look into that myself. I know that there are translations of some of the like cognitive behavioral therapy for insomnia resources out there. But overall, I think we're trying to do more in terms of translations across the board. Todd, you mentioned the the person who had just like incredibly severe, really life-threatening sleep deprivation, and also in talking about sleep restriction and trying to kind of condense the where people are sleeping. Is there sort of a cutoff? One of the participants mentioned that there's some people they know who only sleep for like 4 hours, and they do this for years and years and years, yet they seem functional.
Yeah, there is a small subset of the population that actually 4 hours is their thing, and it's what it is. Chronic insomnia can last for most people. When you talk to them about it, they'll say they were never good sleepers. So it's this state of hyperarousal. And what I usually recommend for those individuals is they probably would function if they got maybe even 1 or 2 hours more. If they could get 6 hours in, they would do better than 4. So it's, I'm sorry if I'm making it sound like there's like this hard cutoff at 7 hours, you're gonna die if you don't get 7 hours of sleep a night. But there's probably, if they're functioning well and they're doing really, really well, that would be one thing. But if they're having problems getting even 1 or 2 hours of sleep, and it's really using some of these techniques of sleep hygiene to try and see if you can just get a little bit more sleep. But oftentimes they'll say 4 hours of sleep is all I ever needed. They weren't good sleepers when they were kids. They weren't good sleepers as adults. They're kind of hardwired that way, and it's really hard to pharmacologically override that system. But even if you could get 1 or 2 hours more out of them, they would probably feel better.
Yeah, and I've had similar, I've had folks I've worked with for months and months or even a year trying to address sleep, and in the end they're one of those few people where they sort of seem to get by and do fine without with very few kind of objective signs. But it's actually, I find people are even just stressed knowing that they're not getting enough sleep, even if they don't actually feel any sort of effects of that. Yep. There's questions around screen time. This is specifically around younger populations, but I'm curious about folks in general. Yeah. Is my habitual Twitter usage causing me trouble at night?
Yeah. So probably. Again, there's a lot being written about it right now. If you really look at the basic core recommendations from the sleep docs, they would say that 1 to 2 hours before you want to go to sleep at night, you should stay away from bright lights and from the blue lights. You really, and again, this sort of gets it to basic bedtime routine. Boring is better. So trying to set a specific time that you go to sleep so you can be cued to your circadian rhythm. And in the couple of hours before that, really being very mindful about screen time, staying away from brightness, sort of darkening, making things just a little bit darker, a little bit quieter, not exercising, not eating a lot of food, not listening to a lot of racy music and things like that. Definitely, and it's so hard to get away from screens. I know I'm compulsively checking my email the hour before I go to sleep, especially during COVID tide, to be able to make sure I got to know what I'm doing tomorrow morning and what's going on. And it's super challenging. But if you can really 1 to 2 hours before you go to bed, get rid of the screens, or at least I guess the blue light filters in some of our phones are somewhat helpful. I don't know that they're a game changer. It's more the idea of getting into a darker place, less light.
Great. Yeah, and when we've got just a couple of minutes left here, and so seeing if there's any sort of kind of other remaining questions. Folks are asking about the recording for today's session. We'll have that available. We'll send it out to folks who registered for today, but also it'll be posted to pcdc.org/sleep. Pretty easy to remember. and that'll be available in a few days. You can actually go there now and check out our most recent recording from the pre-session on sleep within health centers. But we'll have lots more to come, and I'd encourage folks to tune in for our next sessions. We're going to really be getting into health disparities in particular and talking about, elaborating more in terms of what we know about discrimination in sleep, particularly for adolescents. We'll be talking to researchers in the field and others. Dr. Wahrenberger, any other comments, anything that you want to let the folks here know about, or and we've got your email address there as well. I'm sorry if folks reach out to you.
Yeah, I was just looking at one. Kelly was asking about people that sleep up later, wake up later in the night. Just some get rid of the clocks in the bedroom. Sometimes people will have a clock there and they'll just keep looking at the clock when they wake up, and that'll prevent them from falling back asleep. Ask them about their relationship with alcohol. A lot of people use a little bit of alcohol to help them go to sleep, and then they'll have rebound later on at night that will be very problematic for them. And so those are a couple of ideas around waking up. For some people, it is normal to have sort of this, they'll wake up in the middle of the night and they'll go back to sleep and sleep a few more hours. Usually they're ruminating around worry or fears in the middle of the night. And hopefully we'll be talking about that more in future talks about some CBT information to help them with that.
Yeah, absolutely. We're going to really get into the behavioral components, I think, in February. And I'll say as a health psychologist in primary care, it was when the American College of Physicians, when the American Academy of Sleep Medicine came out with CBTI as the gold standard intervention for addressing insomnia. It cultural wise, in terms of our clinics, really shifted things to kind of understand how behavioral health and physical medicine can really be working together, where they're in places where they've historically been separated, particularly around insomnia. And that's a big reason why we're talking about this here. All right, well, so that is going to bring us to the end of our time. Thank you, everyone, for joining us today. Dr. Wahrenberger, thank you so much. Not only for the great information, but you are also just an awesome storyteller, and it's just great listening to you and hearing about your work. And I know that we'll also be seeing you on other productions from the SAMHSA Center of Excellence for Integrated Health Solutions too. So we'll be looking forward to that.
Okay, thanks so much.
All right, thanks everyone.